Today, I would like to talk about changing the game in poor responders, especially for women with advanced maternal age and with diminished ovarian reserve. Even though the evidence is still evolving and not clear, and there is no enough base data, fertility and sterility has highlighted Duo Stim as a promising option for women who have undergone multiple IVF cycles without reaching the eggs retrieval procedure or without achieving mature oocytes and fertilized embryos or blastocysts. Our goals are to reduce the dropout rates of multiple IVF cycles failure and to lower the burden, especially the financial burden of IVF. So today, let's review the secret behind Duo Stim, what is it and how it works, and why it may offer new hope for candidates who need it the most. The common challenges for IVF specialists, as we know, are women over 40, either newly married or already facing IVF challenges. Because we have decline in egg quality and quantity, making conception more difficult, we have more cycle dropouts, we have failed fertilization and halted embryo development, additional difficulties due to the emotional toll of IVF setbacks, in addition to the financial burden associated with repeated IVF cycles. Long waiting periods between cycles, adding uncertainty and frustration too. So here we have also difficult decisions around egg donation. Thus, all these challenges led us to introduce Duo Stim as a new path. It's a new hope, we can consider it. Duo Stim allows for eggs retrieval in a single cycle, reducing the waiting time. So the approach increases the chance of IVF success by retrieving just more eggs. Duo Stim offers a renewed opportunity for patients to achieve pregnancy without waiting for another cycle. This is the game of hope. As we all know, there is a study that showed if women under the age of 35, we need at least 8 eggs to get one healthy embryo, leading to pregnancy. And if a woman above 41, we need at least 16 eggs to lead to one healthy embryo. So what is Duo Stim? It's double stimulation in the same menstrual cycle. Why is it gaining attention, improved oocyte yield, better outcomes? Could this be the future of IVF? Let's get back to the conventional theory of menstrual cycle. All resides here in this picture. This is a cyclic recruitment theory. Yani we have only one episode of recruitment of antral follicles as we studied in the physiology of menstrual cycle. So this collection of antral follicles happens only once. It was in the theory of cyclic recruitment. Due to FSH, elevation of FSH will lead to growth of one dominant follicle, then after ovulation, release of inhibin and estrogen and progesterone, which will lead to apoptosis of all the antral follicles. But this was in the past. Now we have two new theories. There is no cyclic recruitment theory. Here comes the science behind Duo Stim. We have continuous recruitment and waves theory. What are the theories? Studies over the past 70 years have resulted in the development of 3 theories of antral follicular development. Cyclic recruitment theory, we talked about it. This is the basic of physiology. However, we started to think about other theories. We have continuous pooling of antral follicles, or we have follicular wave theory. The continuous recruitment theory. What is continuous recruitment theory? We know the physiology of ovary. There will be continuous recruitment of antral follicles. This recruitment of antral follicles is continuous throughout the menstrual cycle. So if we add a little bit of FSH and a little bit of LH, there will be growth of many follicles, not only one follicle, many follicles. But here comes very recent and the famous theory, the follicular wave theory. The follicular wave theory is based on 2 waves or 3 waves during the menstrual cycle. So we have recruitment of antral follicle during the follicular phase, and we have recruitment of antral follicle during the luteal phase. It happens in 68% of women. They have 2 waves. So if we give stimulation during the follicular phase, there will be growth of many follicles, and if we give stimulation during the luteal phase after ovulation, we will get a lot of follicles. And 32% of women have 3 waves. We have follicular phase, luteal phase, and recruitment between the luteal phase and the onset of the next menstrual cycle. How we justify this theory? This is done by histological evaluation of ovaries and by using subsequent transvaginal ultrasound that support the notion that multiple waves of antral follicles developed throughout the menstrual cycle. So we can, if we do ultrasound during the follicular phase and we repeat it during the luteal phase, we realize that there will be difference in diameter of follicles and the number of follicles. So here comes the theory of follicular waves theory. So we have either 2, for every woman we have 2 waves, or maybe we will get 3 waves. This is the interovulatory interval between the follicular phase and the luteal phase. The first 14 days, approximately, we have the follicular phase. Then the rest 14 days, it's luteal phase, luteal wave. Here, 3-wave cycle, we have the follicular phase, luteal phase, and between the late luteal phase and the onset of menstrual cycle, it constitutes the 3rd wave of 32% of women. This is the ultrasound that's shown different diameters. So here comes the concept of Duo Stim. What is Duo Stim? How it works? How it's done? Usually, we can use the conventional protocol, GnRH agonist or antagonist, as you like. I prefer always to use the progestin-primed ovarian stimulation because it's less costly, and in all cases we go for freeze the embryos, freeze all. So we give the optimal dose, the 300 unit of FSH recombinant, and we can include through the 300 unit of FSH 75 LH to refine the quality of eggs. Then we trigger by GnRH agonist, because the agonist has a short half-life, not like HCG triggering. It has longer life, 5 to 7 days. Then we do after 36 hours eggs retrieval. Then after following the procedure of 2 to 5 days, we start another stimulation. This is a luteal phase stimulation by giving the same protocol. So we will get 2 batches of egg collection. Instead of getting 1 follicle or 2 follicles, we can get more follicle, 3, 4, 5. Why is luteal phase stimulation more important? Sometimes we realize that even when we start stimulation during the luteal phase, we can get more oocyte, more responsive oocyte due to the high level of estrogen and progesterone released by the corpus luteum or released by the follicles. And this may lead to an increase in angiogenic factors, thereby promoting the sensitivity of granulocyte to FSH. We have better synchronization also because of the level of estrogen and progesterone. Studies showed no difference have been reported in the final neonatal birth defect rate in embryos obtained during the follicular phase or luteal phase. Taken together, the results of these studies suggest that obtaining oocyte at the luteal phase stimulation stage results in higher number of embryos. However, a future study are required to confirm this conclusion. Why consider Duo Stim? Is it to increase the oocyte yield, to increase euploid blastocysts, or cumulative live birth rate, or time to live birth? Here come the first systematic review published by Gruzovsky in 2020, found just one randomized control type and 3 other comparative studies that Duo Stim with a single conventional stimulation in women led to more number of M2 oocytes. But the evidence was unclear for more relevant outcomes such as clinical pregnancy, live birth, and miscarriage rate. However, here comes the shock that Duo Stim did a randomized control trial in 2023 on only in 83 women. They didn't show any improvement for the Duo Stim. We have on the opposite side, we have lower number of usual embryos and lower number of M2 oocytes in Duo Stim. And another study, randomized controlled study by Cirillo et al. Also find no significant numbers of M2 oocyte, but lower number of euploid blastocysts in Duo Stim. But these studies have limitations. There are confounded variables and smaller sample size of study. Does it decrease dropout rates or more oocyte in a restricted time? Yes, Duo Stim is proposed as an ideal strategy to prevent treatment discontinuation. Duo Stim reduces the time between the first and the second oocyte retrieval. 15 days in Duo Stim versus 140 days if we go for repeated IVF cycles after waiting for the result of beta-HCG. Is it cost effective? Yes, it will be cost effective. If we go for Duo Stim, then the woman achieved a pregnancy rate positive. It's very important to oncologic patients. We are shortening the time between IVF cycles. We are collecting more eggs, so we are collecting more embryos after starting before starting the chemotherapy. Do we have enough evidence to use it? This is a SWOT analysis. The strengths of Duo Stim, we have higher number of oocyte and embryos obtained per ovarian cycle, more patients obtaining competent blastocyst per ovarian cycle, no difference in competence between oocyte obtained after follicular and luteal phase stimulation. The weaknesses, we have higher number of stimulation cancelled in the luteal phase. We don't know why, maybe because of protocol of stimulation. No randomized control trial or cost effectiveness analysis is performed. Freeze-all approach is mandatory, applied only to poor prognosis patient, reduced ovarian reserve and advanced maternal age, and always after counseling. Counseling comes first. Who are the best candidates? We have patients with low ovarian reserve, the Poseiton criteria 3 and 4, and Poseiton criteria subgroup 1A and 2A. Oncology patient, Poseiton criteria 3 and 4, we have women less than 35 years and above 35 years, and we have AMH less than 1.2 ng per ml, and AFC less than 5. Oncology patients needing rapid fertility preservation, those with limited time for multiple cycles, recurrent failed oocyte retrieval procedures in patients using conventional IVF protocols. Duo Stim is a promising approach for poor responders. In oncology patients, we need rapid fertility preservation, less dropout, shorter time to eggs accumulation. We have to consider individual factors before applying this strategy. Always, always individualization. Proper randomized control trials are needed, including total number of eggs and good quality embryos, cost efficacy, and dropout. Here, this is a case study I have done recently. I've done more than 53 cases in the past 6 months, but this is a very interesting case, a 42-year-old woman with diminished ovarian reserve, AMH 0.6, with multiple IVF failures, 2 cancelled cycles, and 1 cycle with no fertilized egg. This is the medical history of this patient. So, can we maximize her egg retrieval in a single cycle? I counseled her about Duo Stim and about the failure rate. She knows about it. We started with luteal phase stimulation, 8 days of ovarian stimulation triggered with GnRH agonist, then egg retrieval after 36 hours. I used here the PPOS protocol. We got 3 M2, 3 fertilized eggs, 3 embryos grade 1 on day 3, then only 1 blastocyst, AA. on day 5 and cryopreserved. 5 days after first eggs retrieval, started with another stimulation for 8 days. I got 2 embryos grade 1 on day 3 and 2 blastocysts AA on luteal phase stimulation. And the third embryo transfer was done after 2 cycles, and natural cycle of FET of 2 blastocysts was done. And we saw 1 single gestational sac with positive heartbeat after 2 weeks of beta HCG. Age is just a number, but science gives it a meaning. Would you give a trial of Duo Stim? Thank you.